All fine?
Yes, all good.
Great.
Thanks.
So a bit of context for this. So me, Keaton, and Riley participated in the WA Health Hackathon. So that was on the 14th of August, so just over a week or so ago. And then we got into the finals where we went and presented again on last Thursday and won with this presentation and for the work we did. And so we were competing against a collection of different teams, ranging from data science professionals to students, to people that just had just a general interest in the healthcare sector. And so the challenge we were working on was the early detection of sepsis, and I'll get into the presentation that we presented now. So yeah, so I'm Broderick. We've got Riley and Keaton as well on the call. And we were looking at the early detection of sepsis as our challenge. So we met with a domain expert, which was a doctor in the emergency department at Sir Charles Gardner Hospital, and worked with them to try and see if we could find a solution to this problem. So taking a step back and just outlining a little bit of the scope of what we're working on. For those that don't know, sepsis is the body's response to infection, and left untreated is often fatal. And I've pulled out a few statistics here on sepsis just to outline that a bit further. So 50 million cases of it occur per year, and it's actually the cause of 20% of all global deaths. And unfortunately, 3 million of those deaths are from children under 5. So honing in a little bit more, I've just mapped out very, very roughly the patient journey that someone may have at the hospital. So they'll present at the emergency department where they're seen by a triage nurse who will assign a priority to them, examine their symptoms and treat them as possible. And if further treatment is required, they may be admitted to hospital. Then subsequently, if their situation deteriorates or more intensive care is required, they can get admitted to the ICU. And unfortunately, at the moment, only about 20 to 25% of sepsis cases are identified at ED presentation. And so this red line is just sort of representing where these sepsis cases are getting detected a bit later in that patient journey. And this is particularly bad because early detection is really critical for good outcomes. So mortality increases by 7.6% per hour that sepsis is left unidentified and untreated. So our goal was to move this red line earlier and to see if, based on the triage notes and the emergency department data, could we predict which patients were at risk of developing sepsis earlier in that patient journey. So I'll hand over to Riley to explain a little bit more about the data.
Thanks, Rod. So a little bit about our data. So we had two data sets we were working from. The first one was from the emergency department, titled the ED data. And then the next was admissions data, which is from when they actually entered the hospital proper. So a key thing to note is that we were only looking at patients where there was no sepsis identified initially on ED presentation. We discluded these because we figured if they're already being identified, we don't really need to use our model to identify these patients because we wanted to focus on people who are getting missed. So to talk about the approach we wanted to take, so initially we had to clean our data. So, and then we also had to remove any data we thought was sort of unrealistic to have early in the patient journey. So this was like total time of stay, when they checked out, those sort of things, because obviously we're not going to have those while they're in the hospital. We then had to extract the keywords from the triage notes and then other potential features such as time to treatment within the ED or age. We then created a nice little data set and plugged into our machine learning model to hopefully get some good results. I'll now pass on to Keaton to talk about the keyword extraction.
Thanks, Riley. So a big focus of our model was trying to leverage these triage comments. So get a sample one here, and these are essentially the clinical notes that the nurse takes for each patient upon their admission to the ED. So for that, we use natural language processing, which, for anyone who's unaware, is just sort of a way to leverage the words and language and convert them to a statistical representation, which can then be used for modeling. So specifically, we use the bag of words approach, which essentially looks at the frequency of each word. And the way we go about processing the statements is first we take this one and we tokenize it. So you break it down into the individual words. Then you look for bigrams, which are words that frequent together, such as blurred vision and HR irregular or heart rate irregular. Next, we look for negated words. So you can see here that this patient, for instance, has no chest pain or fever, and the bag of words approach would get rid of that context. So the idea is to try and tie that in beforehand. And so we represent that as chest pain neg and fever neg. Then we get rid of any of the irrelevant connector words, things that don't add any importance. And finally, we look for any other pertinent words. Then comes the vectorization step, where we essentially cross-reference it with a previously extracted dictionary of medical terms. And this generates a vector comprising of zeros, which indicates a word's absence, and ones, which is a word's presence. So you can sort of see a sample one there. And so that's done for each patient's triage comment and sort of tied in with the ED data, which was then subsequently used for the modeling. So as for the actual results, to sort of illustrate the performance of the model, what we have here is a receiver operating characteristic, or ROC curve, which plots the sensitivity, which is the proportion of sepsis patients who were positively identified or correctly identified against the false positive rate, which is the non-sepsis patients who were not identified or who were misdiagnosed, sorry. So the objective essentially is to maximize sensitivity and minimize the false positive rate. And for reference, what we have there is a perfectly random guessing model, which is represented by that dotted line. And so generally speaking, the further your model tends to deviate from that, well, the better. So the way this works is it's a constant trade-off between sensitivity and, one other thing. Sorry, this red cross here illustrates the performance of the existing clinical protocol for detecting sepsis in the ED. So you can see that our model is able to outperform that, which shows some obvious promise. So again, the way this works is it's a trade-off between the two. So you can make your model incredibly sensitive to sepsis, but that then increases the risk of false positives, and you might be identifying or misdiagnosing more patients. So for example, to achieve 80% of the sepsis diagnoses and identify those, well, then 28% of the non-sepsis patients are misdiagnosed. If you want to increase that threshold to 90% of the sepsis cases identified, represented by this orange dot, well, then 47% of the non-sepsis patients are misdiagnosed. So were this model to be supplied to the clinician, or I guess to any given hospital, their choice of the threshold would ultimately be determined by the resources they have available. So for instance, a larger public hospital with more resources could accommodate more of these misdiagnosed patients, sort of clogging up, if you would, the sepsis treatment clinical workflow, whereas a small private clinic might not be able to do that. So they might have to compromise on their sensitivity. Now, since the data set did feature quite significant class imbalance, in fact, only 4% of the patients actually had sepsis, a slightly better metric to represent this is the precision recall curve. And so precision is the proportion of sepsis predictions that are correct. Recall is the proportion of actual sepsis patients that were identified. So again, for reference, we've got their random baseline guessing model represented in the red. And the further your model deviates from that, the better. And finally, some pertinent features that our model was able to identify, which regardless can be passed on to the clinician to look out for, is the triage treatment duration, or how long they spend at ED, the patient temperature, their age, and their mode of transport. So ambulance, say, versus private transport, which may indicate urgency and other such things. Now, for the implementation, let me just pass back to Riley.
Thanks, Keaton. So a great thing about our model is that nothing needs to change with how the hospital is currently collecting data on ED presentation. Our model was built on only the data that was available, and so nothing needs to change. To implement, we can just run it on a patient as after they've been presented and the nurse is taking down the triage notes, and then it would give out an output for the sepsis risk. And then the clinicians can use this to make a decision. And just want to emphasize that point is that this is not going to be replacing clinicians. This is a tool to support them in their decision-making for the patient care. In terms of the impact, this will reduce patient mortality, reduce the hospital costs, as well as increase bed capacity. And then in terms of the next steps, we would liaison with our clinical contact and conduct an observational study. An observational study is just where we run the model in the background as patients are presented to ED, and then we can see how well it's doing as it makes predictions on these patients without actually giving sepsis to people and doing it on that, which obviously is a bad thing. And then we'd also test our model on other hospital data to make it a bit more general. Yeah, and thanks for listening. Any questions?
Thanks very much. Broderick, can you please